session. I am honored to invite Professor Dr. Paul Lohle to speak about vertebroplasty, patient selection technique, and controversy. Please, Professor.
Thank you very much for your kind words and introduction, ladies and gentlemen, dear professors. Thank you very much for having me here. It's a feast. It's great to be back in Cairo. I love Egypt. I love working with you as experts in this field of interventional radiology. I'd like to share some things with you today. My first talk will be about percutaneous vertebroplasty. We'll be talking about patient selection. For those who are less familiar with the procedure, I will talk about the technique itself and, of course, at the end, about controversies regarding percutaneous vertebroplasty. Which button do you want me to press? This one or this one? This one, right. Thank you. Vertebral compression fractures. Well, vertebral compression fractures can result, as you all know, in pain, local back pain, serious local back pain, long-term morbidity in these patients, and also spinal deformity, as you can see on this slide. In case of osteoporotic vertebral compression fractures, conservative management includes things like opiates and other analgesics, bed rest, and bracing. But there is an alternative treatment option, which is percutaneous vertebroplasty, which works very quickly and is very successful. Percutaneous vertebroplasty is a minimally invasive technique in which cement is injected percutaneously under local anesthesia, and there's no general anesthesia needed. Through an inserted needle into the vertebral body to reinforce the affected and broken vertebra. The main goal is localized back pain relief in these patients. The positive results of pain relief is due to the mechanical stabilization effect of cementing microfractures and undoing micro movements within this vertebral body. A little word about the history of vertebroplasty. It was first done in the north of France in 1984 in a place called Amiens, the University of Amiens. And the first procedure was done by Professor Hervé Eramont. He's really the godfather of vertebroplasty, and he published about it in 1987 in neurosurgery. Now, what about the indications for vertebroplasty? Of course, we can treat vertebral bodies that are affected with hemangiomas, the benign tumors, or the malignant tumors like multiple myeloma, plasmacytoma, osteolytic bone metastasis, but I will only focus today, because of time, on osteoporotic vertebral compression fractures, fractures due to osteoporosis. What about patient selection for vertebroplasty in these very painful osteoporotic vertebral compression fractures? Well, first of all, you need to have a severe back pain due to such an osteoporotic vertebral fracture. You need to have local back pain at the level of the fracture in the spine with a VAS score of 5 or higher up to 10. You need to have a fracture on your X-ray, as you can see on the left side, and bone edema on MR, as you can see on the right side. This is how we select our patients for this procedure. Once we've selected these procedures, we bring them to the angio suite, where we bring inside the vertebral body two needles transpedicular, as you can see on both images. Once the needles are in there, in the vertebral body transpedicular, we remove the stylet, and through this whole needle, we inject cement. As you can see here on the right side, the cement is nicely inside of the box of this vertebral body. And this is the view from sagittal. Again, the cement is nicely inside the vertebral body without any leakage in the surrounding tissue. There are also contraindications for vertebroplasty. Some are absolute and some are relative contraindications. Please do rule out local back pain symptoms caused by osteoarthritis or a hernia, and also infection like osteomyelitis, spondylodiscitis. These patients are not good candidates for vertebroplasty. Coagulation disorders, any allergies or compromised cardiopulmonary conditions, that's also contraindicated in these patients. You need to check whether the patient is able to lie prone, a prone position which is very necessary for this procedure. And you should also arrange neurosurgical or orthopedic surgical backup in case of problems and complications. What about the procedure? Well, first of all, we bring the patient in a prone position. Some are using IV drip infusions with augmentin, broad-spectrum antibiotics. We don't. Then you use local anesthetics like lidocaine, 10 cc, tucked subcutaneously and at the level of the periostrum of the vertebral body, close to the pedicles. The procedure is done in less than an hour. You can do 1 level, 2 or 3 levels. And after the procedure, the patient needs a little bit of bed rest, let's say about 4 hours. Physiotherapy can be given to these patients, and they can be discharged from hospital the same day. So you can do this procedure in an outpatient procedure or as an inpatient procedure. It all depends on you or the hospital where you work. Most interventional radiologists perform fluoroscopic guidance when performing vertebroplasty, and you can use a uniplane system or a biplane system. Both are okay, but personally I believe biplane is much more easy to work with. And then we bring the needle through the pedicle. You can choose the transpedicular approach or the extrapedicular approach, as you can see on this slide on the left and on the right side. It's much more safe to do it transpedicular in order to avoid any problems. Or you can also choose for unipedicular or bilateral approach of your vertebral body. Some people like to work with CT, and then you can easily advance your needles transpedicular in the vertebral body, but most IRs prefer to work on the fluor, but then you only have a lateral or an AP view, and we should respect the landmarks of such a vertebral body. So we have the lateral view and the AP view, and one of the most important landmarks is the landmark of the pedicle. I will show it to you. So when the patient is lying prone, we first start with injecting some lidocaine through a needle subcutaneously at the level of the broken vertebral body. And then we advance the needle close to the pedicle, tipping the pedicle and injecting 8 cc's of lidocaine on both sides in the center of the pedicle. Then we cut a little skin, and then we advance a trocar needle, and the trocar needle is positioned at the edge of the pedicle. So for you at the right side, the trocar is at the edge at 10 o'clock of the pedicle, and on the other side, the trocar needle is at the edge at 2 o'clock of the pedicle. Once you're there, you can slowly advance your trocar needle to the center of the pedicle, but respect the markings, the edges of the pedicle. You should stay inside and go for bullseye. Because there's a danger zone in between, as you all know, there's the myelin. We should respect the myelin. We don't want to have any more trouble. And also, we should also take care of the danger zone around the vertebral body, like the kidneys, the vena cava, the aorta, and so forth. So let's have a look at this sagittal view. This is the danger zone. We should stay with our needle inside the pedicle on the left and the right side from the danger zone. And once we have crossed the dorsal wall of the vertebral body, we can then center our needles inside the center of the vertebral body. Once you have crossed the vertebral dorsal wall, you're inside the safe zone. Only after passing the dorsal wall, you are allowed to cross the medial pedicle wall and center the vertebral body. Advance the needle until the frontal 1/3 of the vertebral body in this lateral projection. That is very important. And then you can remove the stylet, and through this hollow needle, you can inject the cement. But when injecting the cement, we should watch out for any cement leakage in the discal space up north and south, or in the veins left and right from the vertebral body, but most importantly, leakage into the epidural space, as you can see on the right side, or anteriorly in the vena cava. We're using different types of needles. I prefer to work with an 11 or 13 gauge needle in different lengths, 10 to 15 centimeters. You can use side bevel needles or diamond-shaped bevel needles. And the cement components that I prefer to work with is the PMMA. It's polymethyl methacrylate powder, combined with a monomer. It's a liquid suspension, and a radiopaque material. You can use tantalum, you can use tungsten. We prefer to work with barium sulfate to make the cement visible on the angio, on the fluoroscopy. And then there are two options to advance your needles. You can hammer the needles inside the vertebral body, but you can also use another approach, is needles with handles, and then you position your needles slowly, transpedicularly into the vertebral body. Here, one of my residents is doing her job, positioning the needles inside the vertebral body. There they are, and once we have removed the stylets with the hollow needles staying in place, we inject slowly the cement into the vertebral body on the close visualization during our fluoroscopy. And this is an image you've seen before. The cement is nicely inside the box of the vertebral body. Complications do occur, but fortunately only very few. The most dramatic complication is, of course, spinal cord lesions due to leakage of cement in the epidural space or by damaging the spinal cord with your needles. So always respect the boundaries of your pedicle. You should stay inside with the needle in your pedicle whenever advancing these needles. Nerve root damage has been reported, and that can give complications temporarily or permanently, muscle or nerve pain temporarily or permanently, pulmonary embolism that is also something to be respected. You can have cement leakage through the vena cava, through the heart, into the lungs, and that can be the cement, but sometimes also the fat that is displaced while injecting the cement, so be careful with that. Rib fractures have been reported, pedicle fractures, and infections. Here a case of cement leakage. You can see there is cement leakage on the left side of this vertebral body in the veins. That doesn't harm the patient that much. But there's also leakage of cement into the epidural space, which is, in this particular case, okay, but it can become much more dramatic, causing all kinds of serious problems, as you all understand. And on the right side, there's again leakage in front of the vertebral body. Try to avoid these kind of complications. And then this is also leakage. We call these cement spikes. When removing the needle, you should take care of the cement because it will cause cement spikes. Be careful with this. Cement leakage, like I said, can through the vena cava into the lungs. As you can see here, there is a little sparkle of cement on the left side. Fortunately, not clinically relevant, but these things can be more dramatic. Be careful with that. Here is some cement leakage into the discal space, and this is severe cement leakage, and this has caused nerve root damage to the patient. And this is a more incredible cement leakage, a lot of cement in the epidural space causing spinal cord damage. Vertebroplasty provides significant pain relief. The average pain reduction on the VAS score is significant. On average, before vertebroplasty, the pain score is around 8, and after vertebroplasty, it drops significantly down to 3, and the success rate is about 90%. Now, what about secondary fractures after vertebroplasty? Does this hard, solid cement component used in vertebroplasty, could it cause increased risk of more vertebral fractures adjacent to the treated vertebral body, or maybe higher up or lower down? Yes, we know that in 25% of the cases in the first year after vertebroplasty, there will be more fractures. And in 50% of the cases, it is symptomatic. But this is not due to the cement. It is not due to the percutaneous vertebroplasty procedure, but it's due to the illness of osteoporosis that has already been proven by many studies. 50% of the new fractures, secondary fractures after vertebroplasty, is adjacent to the treated vertebral body with cement, and 50% is remote from the treated vertebral body. Then what about the evidence? What about evidence-based medicine for vertebroplasty? Well, from the beginning, when it all started in France, by Professor Deramont, until 2009, it was concluded that vertebroplasty is very much effective with a 90% of success rate and is very much safe with only very few complications in the treatment of osteoporotic vertebral compression fractures. But more prospective randomized controlled trials were still missing at the time, and there were still no sham randomized controlled trials at the time. But then an interesting study popped up from the Netherlands. It's called VERTOS 2. It's an open-label randomized controlled trial named VERTOS 2, and it confirmed the advantages of vertebroplasty over conservative therapy. Have a look at this graph. On the horizontal axis, you can see time. On the vertical axis is pain. Conservative therapy is the blue line, And starting with a VAS score of around 8, you can see that even with conservative therapy, these patients do a bit better the months and weeks after. But with vertebroplasty, there's a quick reduction in pain and a much better solution for pain in the weeks, months, and years after. So vertebroplasty works much better than conservative therapy, and it's been published in Lancet. But then, in the year 2009, there were 2 sham randomized controlled trials from Australia and the United States who disputed the effectiveness of vertebroplasty and found no short-term benefit of vertebroplasty when compared to controls. There was no significant difference in pain reduction between these patients with vertebroplasty or the sham intervention, the placebo group. But watch out for this. Of note, these 2 controversial and subsequently downgraded articles included fractures of all ages. They included acute fractures, subacute fractures, chronic fractures. We're looking at apples and pears, and as such were underpowered to determine the effect of any fracture age group. It all resulted in intense discussions. These conflicting results gave rise to discussions and controversies all over the world about vertebroplasty. And this has led to the development of more sham randomized controlled trials, and I'd like to share with you just 2 very important studies. The first one is being published in 2016 and comes from Australia from Bill Clark. It's a sham randomized controlled trial, it's called VAPOR. Demonstrated a sound and clear benefit of vertebroplasty regarding pain relief when compared to sham intervention, with a significant difference in pain reduction after vertebroplasty compared to sham for acute fractures. What does it mean, acute fractures? Those are fractures not older than 6 weeks. And then in 2023, another sham randomized controlled trial popped up, and it's called VERTOS 5, demonstrating significant better pain relief and better health-related quality of life after vertebroplasty in patients with chronic vertebral compression fractures. What does it mean, chronic? Those osteoporotic fractures were 3 months or older. Let's have a close look at the VAPOR study. Vertebroplasty provides significant better pain relief in these acute fractures not older than 6 weeks. The pain score drops significantly. As you can see, the dotted line representing vertebroplasty does much better than the placebo line. And then VAPOR also showed that there is a significant less vertebral body height loss after cementation. If you look at the placebo group, there's 63% of further fracturing in the placebo group, whereas in the group that has been cemented, the fracturing only occurs in a minority of cases, around 25%. So there's a significant difference between the 2 in favor of vertebroplasty. Let's have a look at the VERTOS 5 study. Again, significant better pain relief in chronic non-union vertebral compression fractures. And again, you can see in this graph that the vertebroplasty group, which is presented by the blue line, provides much better pain relief compared to sham intervention. This graph illustrates that both study groups showed the same VAS score decrease only in the first day. However, after the first day, in the weeks and months further, it shows that vertebroplasty does much better, with a significant difference between the groups. Now, these VERTOS studies showed significant less vertebral height loss after cementation. There's much less risk of height loss of these cemented vertebral bodies with 1-year follow-up. If you look at the placebo, the controls, 45% continue to have more fractures of this treated body, whereas in the cemented group, the fracturing is only 8%. So apparently, cement protects against further height loss. Let's have a look again at the VERTOS and sum up. The VERTOS study proved that cementation prevents further height loss compared to progressive severe height loss after no cementation. It also proved that cementation itself does not provoke any risk of fractures at adjacent or remote spine levels. And the VERTOS studies also proved that cementation protects against progressive spine deformity. So when using cement, the spinal column remains upright, as you can see on the left side. If you're not using cement, for instance, conservative therapy, the spinal column becomes progressively kyphotic. Let me end by showing you some comments from key opinion leaders from the United States. And I quote their statements: "The high-quality data provided by VAPOR and the VERTOS 5 study support the treatment of vertebroplasty for painful, acute, and chronic non-union vertebral compression fractures. These studies are a very important addition to the literature, adding to previous lower quality data and existing expert recommendations. The next step will be to incorporate this information into better care and treatment recommendations, and our ultimate goal is to provide the best improvement in pain and quality of life for these patients with these painful vertebral compression fractures." So to conclude, ladies and gentlemen, vertebroplasty is a minimal invasive treatment. It is safe and effective, providing sustained pain relief in patients with affected, acute, and chronic painful fractures. It protects against further vertebral height loss with significant, durable improvement of health-related quality of life. I want to thank you for your attention.
Thank you, dear Professor Paul, for your nice and comprehensive talk. I think the discussion will be at the last of the session.
Thank you.
Thank you. Thank you so much. Now we shift for the second speaker.